Hello everyone. My name is Mohit Kumar from group 317. Today my topic is about pressure in cardiac cycle. So there's some objectives shown in the diagram. Introductions. A single cardiac cycle include heartbeat, that is one heartbeat, and it consists of systole and diastole of atria and the ventricle. When heart rate is 75 beats per minute, its cardiac cycle is all about 0.8 seconds. Pressure and volume changes during cardiac cycle. In each cardiac cycle, atria and ventricle alternatively contract and relax, forcing blood from areas of high pressure to low pressure, while in chamber of heart contract, your blood pressure it increases from high pressure to low pressure. The first is atrial systole. Atrial systole lasts about 0.11 second and atrial diastole is all about 0.369 second. Contraction of atria is responsible for final 20% of ventricle filling. His diagram shown atrial systole. SA node is mainly responsible for atrial systole, its impulse conduction, and SA node also increase the heart rate. When the blood pressure is low, heart rate is automatically increased, and atrial systole caused by the atrial depolarization when sodium entry in nerves of heart. We can see some also pressure in diagram A show the jugular venous pressure. Here we see the how atria contract and the pressure occurring jugular venous pressure. In heart there is a superior vena cava, in inferior vena cava. In superior vena cava, upper blood coming, in inferior vena cava, lower body blood goes to the right atrium where SA node present. Little blood pump back into venous tributaries during brief atrial contraction because of inertia of inflowing blood. Inertia main role in biophysics. Left ventricle pressure at the end of atrial systole also represent the left ventricle and diastolic volume. There is the atrial systole contribute 25 ml of blood, whereas volume of 105 ml already in each ventricle. The right or left ventricle, there is a rapid and reduced filling phase. Each ventricle contains 130 ml at the end of relaxation period, which is called as diastole, which is also known as end diastolic volume. Atrial systole have fourth heartbeat, which occur during atrial systole, audible in pathological condition resulting in forceful atrial systole. Here we can see also in diagram reduction in left ventricle compliance due to hypertrophy or infection. Hypertrophy means number of cell, number of size increases. We can see the atrial contract by SA node, how impulse goes from SA node to AV node, then AV node to Purkinje fiber. It travels. The travel is called impulse, and at point we can see the jugular venous pressure. Jugular venous pressure and P waves, that is atrial depolarization, we can see in ECG or EKG machine. Second is your ventricle systole. The systole in ventricle, contraction in systole, the pressure in systole. It lasts about 0.3 second. Ventricle contracting and at same time atria also relaxed. When ventricle contract, atria also relaxed. When this is called isovolumic contraction. Isovolumic contraction means constant volume without change in length of muscle fiber. Without change in length of muscle fiber, blood are equal in four ventricle, which is called isovolumic contraction. In graph we can see isovolumic contraction, and also there is a ECG QRS complex, which is ventricle depolarization. Just start at the beginning of isovolumic contraction triggering ventricle. There is a ventricle systole, which is also called as isovolumic contraction occurring when the pressure in left ventricle increases and the pressure in left atria decreases, and there is a closing of mitral valve. There is a closure of mitral valve and tricuspid valve. There is no effect of tricuspid valve because left atria and left ventricle. In left ventricle, pressure continuously increase, and in left atria pressure continuously decrease, and the loudest and longest continuing in early ejection. When left ventricle pressure continues to rise, we can see the loudest noise until the aortic pressure is reached. Left atrial pressure when increases. When the left atrial pressure increases, there is a bulging of mitral wall. This thing bulging at the beginning causing C wave. We can see in jugular venous pressure C wave. During this interval, second is isovolumic contraction. During this interval, cardiac muscle fiber are contracting and extracting force, but not yet shortening. As a result, muscle contraction is isometric. Isometric mean what is isometric? We see in diagram mitral valve and in tricuspid valve we can see all four valve are closed: pulmonary valve, aortic valve, tricuspid and bicuspid. Ventricle pressure and volume changes seen in isovolumic contraction when the pressure is at 8 mmHg and 80 mmHg when aortic and pulmonary valve open passively. In passively mean there is no need of ATP. In active process there is a need of ATP and the volume remains same that is 130 ml to 150 ml. Note, this is the period of auto ejection. Second is rapid ventricle ejection. Rapid ventricle ejection mean we can see in our left ventricle pressure. When the more pressure applied on left ventricle, there is a rise of pressure in aortic pressure and there is the opening of aortic valve. It's defined the ventricle ejection and continues to rise of slower rate until maximum lower ventricle pressure is reached. When the rise of aortic pressure and opening of aortic valve. Aortic valve is open and most of ejection occur because of apical beat. When another beat which is called apical beat. When the aortic valve open, we can see the apical beat and there also we can see diagram pulmonary valve also opening due to this pressure. Due to this pressure, at this we can see ventricle volume graph as shown. First AXC, that is jugular venous pressure, and second we also see ECG peak for atrial systole, QRS complex which can see in ventricle depolarization, and depolarization mainly occur due to sodium entry channel. Next is ventricle systole, we can rapid ventricle ejection. In pulmonary veins we can see in pulmonary vein when the left atrial volume begin, there is a closure of mitral valve. In diagram we can see then jugular pressure vein goes to the V diagram and atrial pressure suddenly constant and the graph goes to ECG in T wave as the marking the ventricle repolarization are recorded in ECG, that is electrocardiography. Ventricle systole is last about 150 milliseconds. During this phase, ventricle ejection shows because of basal beat, and the left ventricle volume more slowly decreases. It's reaching minimum about 40 ml, which is called as end systolic volume. Left atrial volume continuously increases for reduced ejection. When the left atrial pressure also continues to increase, we can see jugular venous pressure and T waves in ECG. And the pressure volume changes during this phase. Pressure pause first increase from 80 to 120 mmHg, then decrease until aortic and the pulmonary valve close. First pressure increases from 80 to 120 mg. Then after ejection of 90 ml, there is a stroke volume, that is end diastolic volume, change from 130 ml to 40 ml. There is a change in pressure and volume during this phase. Which phase? Ventricle systole. In ventricle systole there is a reduced ejection. Second is ventricle diastole. Coronary arteries fill with blood during diastole because compressed during ventricle systole. Its duration depends on heart rate and it is divided into 5 phases. First is protodiastole. At the end of ejection phase, pressure in ventricle and aorta are almost equal. It's close to semilunar valve. Pressure in ventricle is lower than in pressure in aorta and the pulmonary artery in protodiastole, and ventricle pressure is slightly reduced when the closure of aortic valve and the closure of pulmonary valve. We can see in the graph the protodiastole movement seen in atrial pressure in ventricle pressure you can see, and in jugular vein pressure is cross the V point, and in aortic pressure it also cross the green notch which is called as dichrotic notch. Dichrotic notch, when there is some closure we can say dichrotic notch, and the sound which is called S2 sound, endovestibular systole and beginning of ventricle diastole we can say the dichrotic notch. And in ventricular diastole, there is a isovolumetric relaxation, is period between closure of semilunar valve and opening of AV node, which is called as isovolumic relaxation. And in graph, we see the isovolumic relaxation in atrial pressure point. We can see isovolumic relaxation, and in ECG, it goes to T wave and cross the green line. In ventricle diastole, third is rapid ventricle filling. There is a rapid filling in which the left atrial pressure continuously increases and the left ventricle pressure continuously decreases, is maintaining a pressure gradient for ventricle filling, because we know when the ventricle fill, when the mitral valve open and a pressure go from high pressure to low pressure, from atria to ventricle, blood goes from atria to ventricle. That's why left atrial pressure increases and left ventricle pressure decreases. Rapid ventricle filling, when the left ventricle volume increases, now it's turned for volume increases, and in left atrial there will be the decrease of volume. So volume goes from high pressure to low pressure. That's mean phenomena low volume to high volume. We can see in jugular venous pressure, it crosses again the green line, and we can see third sound, which is called S3 sound. S3 sound normal finding in children and young adult, not in old age. Audibly only in pathology condition in adult over 30 to 35 year of age. If some disease occur, we can see the sound S3. S3. And next is there is a reduced feeling phase, that is also known as diastasis. Diastasis means it's in ventricle diastole and reduced filling phase, when the left ventricle pressure and volume increased. When the left ventricle pressure and volume increase and the aortic pressure slow due to drainage of blood into peripheral artery. Now the aortic pressure slow and there is a drainage of blood into our peripheral arteries, some and small arteries. And small slow addition to ventricle filling is indicated by gradual increase of atrial, ventricle and venous pressure and ventricular volume. Now we can see in graph, we can see again before the P waves in ECG. Some points of powder. During isovolumic contraction and relaxation, all heart valves are closed. There are no periods in which all heart valves are open. When the heart rate increases during exercise, during decrease of diastole duration, and less time to fill coronary artery and supply heart with oxygen. When the heart rate increases, patient with narrow coronary artery experience chest pain during exertion, and coronary artery chest pain is also called atherosclerosis, and chest pain is called angina. How myocardial contractibility increases by catecholamine, which are adrenergic drug, act on alpha or beta receptor, and there is also decrease of residual ventricle volume and increase of stroke volume and ejection fraction. Note, in severely hypodynamic and dilated heart, residual volume can become much greater than stroke volume. First is isovolumic contraction. Closure of AV valve produce first heart sound. Protodiastole, closure of semilunar valve produces second heart sound. And the third is rapid filling phase, which is third